Great. Thanks, everyone. Thanks so much for having me today. I'm a reproductive and perinatal epidemiologist who studies both social and environmental determinants of pregnancy outcomes. There we go. So I received my PhD in epidemiology and an MA in biostatistics from UC Berkeley, and I'm currently a postdoctoral scholar at the University of California, San Francisco in the program on reproductive health in the environment, which is in the Department of Obstetrics, Gynecology, and Reproductive Sciences. And sort of the overarching goal of my research is to try to understand the links between both social and environmental factors, perinatal health outcomes, and how these can perpetuate inequities across generations. So I'm going to discuss three types of research questions that I study today. So first, what features of the physical and social environment can affect pregnancy outcomes? Second, what mechanisms can underlie those relationships? And third, what are the threats to causal inference when studying these relationships, and how can we address those challenges? So first, I'm going to give just a little bit of background and motivation for my work, and then I'll highlight a few studies that exemplify each of these areas of my research. And then finally, I'm going to talk about my current work and some potential next steps. So studying social and environmental exposures can be really challenging because of the role of history in determining the burdens of exposure. For example, this is the redlining map of Oakland, where I live. And redlining was this practice of classifying certain neighborhoods as quote unquote risky investments. And this was done by the Homeowners Loan Corporation, which was charged with refinancing mortgages at risk of default after the Great Depression. And in particular, Black neighborhoods in Oakland were almost exclusively coded red on these maps. And this permitted the Federal Housing Authority to refuse to insure mortgages for Black families. And so redlining has become this really well-known way to visualize the historical roots of systemic racism and to analyze the ways they continue to shape our communities. But it was far from the only policy to prioritize wealth building among white people. So for instance, people who left the Jim Crow South looking for more opportunity and better treatment faced a myriad of other forms of segregation and discrimination in California. So they were restricted from purchasing homes or conducting home improvements. Black people in Oakland also experienced employment discrimination, including lower pay, the inability to join unions, inability to get training for specialized work, as well as higher commuting costs. And key benefit programs, including Social Security and the GI Bill, were administered in this discriminatory way, which widened the wealth gap between Blacks and whites in California. Black neighborhoods were also disproportionately raised for government projects and rezoned to industrial for commercial projects. The loss of jobs after World War II and the urban renewal of the 1960s and 70s disproportionately affected Black neighborhoods. And together, these forms of discrimination made it harder for Black people to build wealth and to pass it on to the next generation. And this lack of economic and political power means that Black neighborhoods in Oakland continue to experience a disproportionate burden of social and environmental hardships, including poverty, violence, lack of infrastructure, pollution, and fewer resources. So here's a map of the East Bay area that shows the red line areas with the corresponding levels of NO2 pollution and the percent of the population that were people of color in 2010. And you can see that the areas which were previously redlined have higher exposure to NO2. And this is a result of living by the highways or on truck routes to and from the Port of Oakland. And these are also the areas that tend to experience higher poverty, gun violence, lead poisoning, and other toxic exposures, as well as less access to healthy foods, quality green space and recreation areas, credit and financial resources, and quality jobs nearby. So this shadow of history really makes studying these types of social and environmental exposures challenging. They're not, randomly assigned across populations with each new generation, which means that getting meaningful estimates of exposure outcome relationships requires disentangling or isolating one exposure that exists because of historical policies, institutions, or phenomena. And so doing this really requires some creative thinking around natural experiments or harnessing other types of spatial or temporal variability in order to identify the impacts of these factors that would otherwise be too confounded by history. So I'm going to give some examples of how I've attempted to do this to estimate the effects of traffic-related air pollution, community violence, and water fluoridation on perinatal health outcomes. So I've talked a little bit about the motivation behind the exposures that I focus on in my work, and now I'm going to give a quick overview of the outcomes my work is focused on, which are reproductive health outcomes, and in particular, pregnancy complications and birth outcomes. So pregnancy and birth outcomes has this really well-defined exposure period from conception to delivery, and has relevance for understanding health trajectories over the life course from infancy to adulthood and old age. So for example, experiencing hypertensive disorders during pregnancy is associated with elevated rates of ischemic heart disease, and gestational diabetes is linked to greater incidence of type 2 diabetes later in life. Birth outcomes are also associated with health throughout the life course. So for example, infants who are born preterm have higher all-cause mortality in early to mid-adulthood. However, we also know that preconception health can also affect birth outcomes. And in this way, harmful exposures in utero can affect not only the future health of the exposed fetus, but the health of their children as well. And this is especially true for females who are born with the eggs that will later become their children should they choose to have any. So exposures that occur during pregnancy can have health effects that reverberate through future generations. And thus the preconception and the pregnancy period really holds a lot of promise as potentially critical windows for the intervention and prevention for the intergenerational transfer of health inequities. So studying these types of exposures that are shaped by history and their influence on the pathophysiology of adverse pregnancy outcomes requires both this macro and a micro lens. And these can both kind of be difficult to reconcile, methodologically speaking, and especially with respect to the limitations of available data. And this often requires studying different pieces of this relationship, these relationships in different data sets. So my work kind of tries to draw on the strengths of both approaches by using natural experiments and large administrative data sets, and more accurate exposure and outcome information in pregnancy cohorts. So the goal of this is that by combining evidence across both these types of data, we can hopefully build a stronger evidence base for identifying and quantifying causal relationships. So now I'm going to discuss one study that focuses on features of the environment that affects pregnancy outcomes. So this study evaluates whether hyperlocal measures of traffic-related air pollution are associated with risk of preeclampsia in Oakland. And this study was published in Environmental Science and Technology in 2021. So just a quick background on preeclampsia. So preeclampsia is a pregnancy complication defined by high blood pressure and elevated protein in the urine. And it affects about 3 to 6% of pregnant people and increases the risk of severe fetal and maternal morbidity and mortality. So a pregnancy complicated with preeclampsia is more likely to result in a fetal growth restricted or premature newborn. And preeclampsia can result in severe complications if left untreated. It is one of the 4 leading causes of death for pregnant people, with a case fatality rate of 6.4 deaths per 10,000 cases. And in the long term, people who had preeclampsia during pregnancy are at elevated risk for cardiovascular, renal, and chronic hypertensive disease. So previous studies that have examined traffic-related air pollution and pregnancy complications tend to characterize exposure based on the distance from the nearest road, at the level at a central monitor, or based on satellite imagery. But Oakland has these really densely populated neighborhoods near multiple industrial and traffic sources of pollution, with hills and other complex terrain that traditional methods don't really effectively capture. So for example, here's a single air quality monitor in Oakland, and this yellow box illustrates the area these measurements are presumed to cover. However, as I mentioned, the unique topography of Oakland, along with the multiple sources of pollution across the city, means these measurements don't really capture the hyper-localized differences in pollutant levels. So for this study, we collaborated with Dr. Josh Apte, who has partnered with Google to equip the Google Street View cars that drive around the Bay Area with these air pollution monitors. And so this type of mobile monitoring can really identify areas of pollution that are not predicted by models, not picked up by satellite imagery, and that vary non-linearly with the distance from the road. So between May 2015 and December 2017, these Google Street View cars drove around Oakland for about 6 to 8 hours per day, every weekday. And the results from this mobile monitoring showed that the levels of black carbon, NO and NO2 could vary by 5 to 8 times along city blocks in West and downtown Oakland. And so the goals of this study were to use this hyperlocal variability in traffic-related air pollutants to assess whether a hypothetical intervention to reduce air pollutant levels would reduce the risk of preeclampsia among pregnant people in West and downtown Oakland. And we also wanted to evaluate whether the effects of such an intervention would differ by the race or ethnicity of the pregnant person. So for this study, we used electronic health records from Sutter Health. pregnant people who gave birth between 2014 and 2016. We identified cases of preeclampsia using ICD-9 and ICD-10 diagnosis codes, and we included diagnoses for mild or unspecified preeclampsia, severe preeclampsia, and preeclampsia with pre-existing hypertension. And then we linked pregnancies to the air pollutant levels using the residential address at delivery. We then calculated the exposure values in two separate ways. So we used the value associated with the 30-meter street segment closest to the pregnant person's address. And we also used the average of values within 120 meters of their home. And we decided to focus on 3 pollutants for this analysis. So we focused on black carbon, NO2, and ultrafine particles. So ultrafine particles are less than 0.1 micrometers in diameter, and the sources include diesel engines and aircrafts, but they're not always very correlated with PM 2.5. And little research has been done on their health effects, especially during pregnancy. So here's the distribution of the air pollutants across the pregnancies in our study. So to give you a sense of how the exposure among our population compares to the state of California overall, the average annual black carbon exposure in California is less than 0.25 micrograms per meter cubed, while in our population, the average exposure was higher at 0.37 micrograms per meter cubed. However, the exposure to NO2 was relatively low. So for example, the annual average exposure standard for the US EPA for NO2 is 53 parts per billion, while our participants had exposure levels on average of 11.5 parts per million, and even the maximum value of 24 parts per billion was still less than half the standard. There's no standard for ultrafine particles that currently exists either. However, there was a study in Los Angeles in 2020 that examined the association between UFP and preterm birth. And the average modeled exposure for UFP in that study was 12 number times 10 to the third centimeter cubed. And so in our study population, we had higher levels of UFP and black carbon compared to other populations in California, while the NO2 exposure was significantly lower than the regulatory standard. So here are the characteristics of the study population and the observed prevalence of preeclampsia by race ethnicity. So in 2010, the average US prevalence of preeclampsia was 3.8%, while we observed almost double that in our population and almost triple that among the Black participants in our study. So our goal was to estimate the effect of a hypothetical intervention in which we reduce the pollutant levels to the 25th percentile. So these histograms illustrate what that intervention would look like on simulated data to reflect the NO2 exposure levels observed in our study. So basically, any participant that had an exposure level above the 25th percentile would then have their exposure level recoded to the 25th percentile, while those below the 25th percentile cutoff had their exposure levels kept as observed. And so to estimate the effects of this hypothetical intervention, we used log binomial regression and G computation. And we controlled for maternal age, race, ethnicity, health insurance type, smoking history, parity, the season of conception, the Black group percentage with less than high school education, and the Black group percentage with household income below the poverty line. And we included squared terms for age and the pollutant levels to account for potential nonlinearities. And we used a clustered bootstrap at the Black group level to address potential spatial autocorrelation. So here are the risk differences associated with this hypothetical intervention to reduce air pollutants to the 25th percentile in the study population. So on the x-axis, you can see the results for NO2, black carbon, and ultrafine particles. And on the y-axis is the preeclampsia risk difference in percentage points. And we can see the largest associations for NO2, which are on the left, then black carbon in the middle, and then UFP on the right. And the point estimates were similar if we used either the 30-meter or the 120-meter exposure characterization approach, although the associations tended to be slightly stronger for the 120-meter average exposure characterization for each of the pollutants. So next, we stratified to assess whether associations differed by race ethnicity, and we observed that the associations were strongest among the non-Latina Black women, who made up about a third of our sample. So the estimated effect of the hypothetical intervention for NO2 among the Black women was 2.8 percentage points and 3.7 percentage points using the 30 and the 120-meter exposure characterizations. And the estimated effect of the hypothetical intervention for black carbon was 3 and 3.5 percentage points for the 30-meter and 120-meter exposure characterizations. And so this corresponds to about a 30% reduction in the risk of preeclampsia for both NO2 and black carbon interventions. So overall, this study provided some evidence that mobile monitoring can capture variations in air pollution that exist block by block within cities, in which may be missed by other forms of air pollutant monitoring. And the really hyper-local focus of this study helped control for confounding by area level poverty, access to green space, and other potential neighborhood level confounders. So we estimated the effect of this hypothetical intervention to reduce pollutants to the 25th percentile. And we observed reductions in the risk of preeclampsia, especially among the Black participants in our study. So this suggests that reducing air pollutants even far below regulatory standards might help reduce the risk of preeclampsia and reduce disparities in maternal infant health in Oakland. So next, I'm going to move on to discuss a study that uses mediation analysis to identify potential mechanisms underlying the relationships between firearm violence and preterm birth. So identifying relationships between exposure and outcomes is obviously very useful and important, but often there's interest in trying to understand why these relationships exist and how they arise. And so evaluating mechanisms effect can really help or improve our understanding of how social and environmental exposures affect population health, provide more evidence for a causal effect, and establish alternate points for intervention. And causal mediation studies are especially important for social and environmental justice research because they can help acknowledge the source of the inequities while also identifying plausible policy or clinical interventions that can reduce disparities. So for instance, community violence is a consequence of historical neighborhood disinvestment and lack of economic opportunity, and is a feature of the social environment that can affect health. And this can be through both modified health behaviors and potential alterations in the physiologic stress response, which have implications for maternal immune, hormonal, and cardiovascular systems. So connecting the dots between these historical, community level, and individual level factors and their roles in perpetuating health inequities is really important in order to understand their joint and independent relationships with the etiology of adverse birth outcomes and to identify as many places for intervention as possible. So the results from this study were published in AJE in 2020. So firearm violence is geographically patterned across California with similarities to maps of risk for preterm delivery. So here I focused on the Bay Area in particular, but the patterns are really similar across the state. And so there are two research questions I'm attempting to answer in this analysis. So first, is living in a neighborhood with high levels of firearm violence associated with increased risk of preterm delivery? And second, is that relationship mediated by infection, early preeclampsia, asthma, gestational diabetes, or substance use? And the violence data I used for this study came from California's Office of Statewide Health Planning and Development and Vital Statistics. So I created average firearm violence rates from 2007 to 2011 by summing the total number of emergency department visits, hospitalizations, and deaths that occurred to residents of each zip code and divided by the estimated zip code person time. And the injury-related records from OSHPD were classified using the ICD-9 codes, while the death records used ICD-10. For this study, I defined neighborhoods as zip codes, which were the smallest geographic identifiers available from the OSHPD data. And the birth records were geocoded also to the zip code of the pregnant person's residence at the time of delivery. Preterm births were deliveries before 37 completed weeks gestation. And then the pregnancy complications and the health behaviors were identified based on the emergency department, hospitalization, and ambulatory surgery records from the 9 months prior to delivery that then were probabilistically linked to the birth record. And so studying violence can really be a challenge because a lot of forms of social inequality can co-occur, and it can be really difficult to disentangle these by statistical adjustment alone. And so to attempt to address this, we used propensity scores to restrict to comparable neighborhoods. And we estimated those propensity scores using an ensemble machine learning algorithm, where the high violence neighborhoods were those that experienced firearm violence at or above the 90th percentile of firearm violence rates across California. So to estimate the risk differences in preterm birth among the mothers living in the high violence versus the comparison neighborhoods, we used targeted maximum likelihood estimation, and we controlled for maternal age, educational attainment, race, ethnicity, health insurance type, and the month and year of conception. And we also weighted by the inverse probability of treatment using propensity scores to further account for confounding by community covariance. And we used the non-parametric cluster bootstrap with wild type confidence intervals for inference. For the mediation analyses, We used TMLE to estimate stochastic direct and indirect effects, which allowed us to include post-exposure mediator outcome confounders in our estimation. So in the total effects analysis, we found about 0.5% increased absolute risk of preterm birth among the mothers who lived in the high violence versus the comparison neighborhoods. And we saw that this result was driven by differences in spontaneous rather than indicated preterm birth. So next, I'm going to show the results for the stochastic direct effects, which estimate the pathway that I've highlighted here in red, which does not go through the mediators. So just to orient you to the meaning of these parameters, so here's a quick illustration. So each stochastic direct effect estimates the difference in the expected proportion of preterm birth in the high violence neighborhoods versus the comparison neighborhoods. If the distribution of pregnancy complications or health behaviors was the distribution observed in the comparison neighborhoods. So the stochastic direct effect is the average risk of preterm birth in the top group minus the average risk of preterm birth in the bottom group. So here are the results for each of the mediators, separated by the type of preterm birth. And you can see there aren't kind of large differences across the mediators, although the results, like the total effects, appear to be driven by differences in spontaneous rather than indicated preterm birth. So next I'll show the stochastic indirect effect results, which estimate the pathway I've highlighted here in red, which does go through the mediators. And again, to orient you to these parameters, so each stochastic indirect effect estimates the difference in the expected proportion of preterm birth if everyone lived in the high violence neighborhoods, but the distribution of pregnancy complications and health behaviors was first that observed in the high violence neighborhoods and then that observed in the comparison neighborhoods. So each stochastic indirect effect is the average risk of preterm birth in the top group minus the average risk in the bottom group. So you can see we observed the strongest mediation effects among infection and substance use with smaller effects for asthma. And we saw that these associations were also strongest among those with spontaneous preterm birth. And while the magnitude of these effects are strong, or are small, in some cases they do mediate a non-trivial portion of the total effect. So for example, substance use and infection both individually mediate almost 10% of the relationship between firearm violence and preterm birth. So in conclusion, we found that living in a neighborhood with high levels of firearm violence was associated with both maternal and infant health. And in particular, we found that mothers living in the high violence neighborhoods had about 0.5% higher absolute risk for preterm birth, and then that relationship was partially mediated by infection, asthma, and substance use. And we also found increased prevalence of asthma and diabetes among the mothers living in the high violence neighborhoods, which has implications for maternal health over the life course. Thus, any interventions aimed at reducing violence, which obviously is its own very important public health goal, might also have spillover implications for reproductive health. So next, I'm going to take a quick break, have some water, and then I'm going to highlight some of my methods work, which uses simulations to identify and address threats to causal inference in environmental and social epidemiology. So one significant challenge of perinatal epidemiology in particular is live birth bias. And that is often only live births are included in a data set, but the exposure might affect the probability that a pregnancy becomes a live birth. And so this simulation study I led assesses the relationship between environmental hazards, social inequality, and fetal loss, and how these factors can combine to affect the estimation of effects on birth outcomes. And this paper was published in Environmental Epidemiology in 2021. So if there's an unmeasured factor that influences the probability of live birth as well as an adverse outcome, then conditioning on live births can create selection bias. And previous studies have suggested that up to 30% of conceptions fail to become live births, which means the extent of the selection bias could be substantial. It's also possible that social marginalization and discrimination and the corresponding differences in exposure to environmental hazards might affect the strength of this bias across groups. And in this context, simulation studies are especially useful because we don't have any real life data on the patterns or determinants of early fetal loss that can be generalized to the population at large. So we conducted the simulation study with the goal of quantifying the potential magnitude of live birth bias on the estimates of the relationship between an environmental hazard and the risk of preterm birth. And we also assessed whether a higher burden of exposure among socially vulnerable groups can affect the magnitude of that bias. So there are two potential mechanisms that can create live birth bias. The first is collider stratification, which is illustrated in this DAG, in which there is an unknown common cause of fetal loss and preterm birth. So in this example, A is the environmental hazard, Y is preterm birth, C is fetal loss, and U is this unknown confounder of fetal loss and preterm birth. And when we condition on C by limiting our analyses to live births, we can open up this backdoor path between A and Y through U. The next mechanism that can create live birth bias is referred to in the literature as depletion of susceptibles. And this is when the exposure differentially causes those who have an underlying susceptibility to the outcome to experience a spontaneous abortion instead. And so you might notice the DAG for this scenario is the same as in the collider stratification scenario, except this unknown factor U represents susceptibility, which interacts with the exposure and its effect on fetal loss. So here's an illustration of how depletion of susceptibles can create live birth bias. So in this example, the yellow circles represent conceptions. So on the left are the conceptions that are exposed to this environmental hazard. And on the right are the conceptions that are unexposed. And this red outline indicates the conceptions that are susceptible to preterm birth. And this could be possibly due to other toxic exposures. The white X's indicate preterm births. So this is either the conceptions we observe as preterm births or those that would have been preterm births had they survived to term. So the circles with the white X's include both the observed and the counterfactual preterm births. So on the left, we can see that those who are susceptible to preterm birth are, when they're exposed to the environmental hazard, more likely to end up as a fetal loss. So exposure to this environmental hazard causes those who are susceptible to preterm birth to be differentially selected out of the cohort of live births, and this causes a downward bias of the risk difference. So for instance, we can calculate the risk difference in the cohort of only live births is about 0.02, whereas the difference in the counterfactual cohort of all conceptions is 0.1. So we simulated a population that resembled 1 year of conceptions in California. We used linear regression to estimate absolute risk differences, and we compared the estimates from the truncated data set on only live births to the estimates from the counterfactual set, which included all conceptions had they ended in a live birth. And we estimated this live birth bias separately for those who had what we called social vulnerability, which meant that they had a higher burden of exposure as well as a greater risk of preterm birth. And this is consistent with well-documented disparities in preterm birth along both race and class lines, and with a higher burden of exposure to environmental hazards faced by women of color and those who are lower SES. We used Monte Carlo simulations with 1,000 replications to minimize the influence of sample size on results. So I'm noticing that the confidence intervals are not showing up, but that's okay. You can still take away the important parts. So here are the results for how the live birth bias due to collider stratification affects the estimates of risk. So along the y-axis is the estimated risk difference for the environmental hazard on preterm birth. Along the x-axis is the effect of the hazard on the probability of fetal loss. So the estimate in the counterfactual data set is this straight line with the long and short dashes. And if there were a 95% confidence interval, it would be darker. And the estimate in the truncated data set, or the one that only includes live births, slopes downward as the effect of the exposure on fetal loss increases. And we can see in this scenario, the patterns are the same for those with and without the social vulnerability. And this plot compares the absolute bias for those with and without the social vulnerability. So the socially vulnerable group experiences a larger bias, although the bias is small in magnitude for both groups in this case. And when we look at the 95% confidence interval coverage, we can see that even in the most extreme scenario where the exposure increases the probability of fetal loss by 0.2, the confidence interval coverage is not really strongly affected. It's above 90%. Next, we look at the results for bias due to depletion of susceptibles. So this plot shows the risk difference again on the y-axis between the hazard and preterm birth and the effect of the exposure on fetal loss on the x-axis. And we can see a similar pattern as before, but the downward bias is much greater than we observed with the collider stratification scenario. And we can see this even more clearly when we look at the absolute bias by the social vulnerability status, where we can see that the socially vulnerable group experiences a larger bias. The confidence interval coverage is also much more strongly affected in this scenario, with the coverage dropping precipitously, especially those who are in the socially vulnerable group. So in conclusion, this simulation study demonstrated that live birth bias can result in the underestimation of effects of hazardous environmental exposures on preterm birth, especially among socially vulnerable groups who are more likely to both experience the exposure and have greater risk for preterm delivery. Our findings suggest that the exclusion of fetal loss from studies of preterm birth likely biases effect estimates downwards and might hinder identification of harmful exposures. And in particular, depletion of susceptible fetuses resulted in a larger live birth bias, whereas the bias due to kaleidstratification was smaller in magnitude. And we also observed that the extent of the downward bias was more pronounced among the women with the social vulnerability factor. So this finding is especially relevant in the context of the high prevalence of preterm birth among Black women in California and the US. There's not a lot of evidence that exists regarding the determinants of early fetal loss by race in the US. Although one study has found a higher risk of self-reported miscarriage among Black compared to white women in the southeastern states. The male to female live birth ratio, also called the sex ratio, has been used to assess fetal loss, as male fetuses are presumed to be more vulnerable to in utero stressors. So for example, evidence shows that the sex ratio decreased after the September 11th terrorist attacks and after the collapse of the East German economy, and then increased after the Clean Air Act amendments of 1970. Analysis of California births from 1960 to 1996 showed that Black women had consistently lower sex ratios compared to white women in California. So this evidence suggests that Black women might experience greater early fetal loss, potentially related to their higher burdens of exposure to environmental hazards and other forms of racism. In combination with our simulation results, this suggests that current estimates of disparities in adverse birth outcomes by race are likely underestimated. So next I'm going to present some of my current work and some next steps. So now I'm going to talk about the topic of my K99R00, which focuses on the effects of water fluoridation on pregnancy outcomes. And I first became interested in this question after an analysis I worked on in which we analyzed the relationship between community water fluoridation and water fluoride levels in maternal urine, serum, and amniotic fluid during mid-gestation. And we found significant correlations between water fluoride levels and the levels in each of these biologic samples. But as I was working on this analysis, I realized at that time there were no studies evaluating the effects of water fluoridation on pregnancy outcomes in the US. However, several systematic reviews indicate a suggestive association between early life fluoride consumption and neurodevelopment among children. And since children born preterm or small for gestational age are more likely to have neurodevelopmental disorders, I thought it was possible the effects of fluoride on neurodevelopment might be operating in part through adverse birth outcomes. As you may know, water fluoridation is cited as one of the top public health achievements of the 20th century for its prevention of dental caries among children. And it is one of the only public health interventions that is applied to the entire population without any opting in or opting out requirements. So conditional on the water you get, whether or not you receive fluoridated water is unlikely to be a function of your socioeconomic status, your race, ethnicity, or any other individual characteristic. And so this can really promote dental health equality across groups, which can be really dependent on the educational attainment of parents, access to dental insurance, and the ability to afford dental and orthodontic care. However, every public health intervention does obviously have costs and benefits, and there's research lacking about the potential cost of water fluoridation with respect to reproductive health. So in 2018, more than 200 million Americans received fluoridated water. So even if there is a small effect of fluoride on reproductive health outcomes, there could be potentially large public health implications. Additionally, the lack of epidemiologic research on this topic really does allow misinformation to proliferate. And so by conducting rigorous research on the potential links between water fluoridation and adverse birth outcomes, we can try to make sure that any policymaking that occurs around water fluoridation can be informed by evidence. So In this study, I'm interested in estimating the effects on birth weight and gestational age of a hypothetical intervention that would reduce water fluoride levels to 0.7 parts per million and 0.5 parts per million in California. So this first hypothetical intervention corresponds to reducing the water fluoride level for those systems that exceed 0.7 parts per million to the current recommended level, which is 0.7. And the second estimate is the effect of reducing the level to 0.5 parts per million, which is lower than the current recommendation. So for this study, we're using birth records for the state of California. So birth records were geocoded to the pregnant person's address at the time of delivery and then linked to their water system boundaries. And we're linking these birth records to the average level of fluoride that was present in the community water system where the pregnant person was living during the gestational period. And we assigned each pregnancy the fluoride level in the year of the pregnancy. And then if the pregnancy spanned multiple years, we created a weighted average with the weights, the proportion of the pregnancy that was spent in each year. And by carefully evaluating our data generating mechanism or the process by which our data came to exist, we can design the study to be as robust to potential sources of bias as possible. A big piece of this question is what factors might affect the levels of fluoride people are exposed to during pregnancy and whether those factors might also increase their risk for adverse birth outcomes. And so to better understand this data generating mechanism and thus what confounders we need to control for, we need to understand what determines water fluoride levels in water systems across California. So in 1995, California passed a law that all water systems that serve more than 10,000 customers must fluoridate their water once they identify the funds to do so. So this has resulted in a lot of variability in when and where the water has been fluoridated across the state. However, historical data on fluoride levels for water systems across California are not publicly available for all water systems. However, California water systems are required to release a water quality report, also called a consumer confidence report, to their customers every year that lists the detected levels of water contaminants. So this is an example of a water quality table from Compton's consumer confidence report from 2018. And fluoride, including treatment-related fluoride, is on the list of required chemicals. So I began compiling these water quality reports in California for as many years as I could and creating this database of fluoride levels. And to acquire these water quality reports from each district, I've been using all the publicly available records, and in the areas where previous year's records are not available, I've been using Freedom of Information Act requests to request copies of historical reports. And the fluoride levels are actually commonly tested in the source rather than the distribution water. So when a water system had multiple sources of water that they blend before delivering to the consumer, we combine the source levels using a weighted average of sources. So these plots illustrate a portion of the database of fluoride levels by water system in California. So the plot on the left shows the average variability in fluoride levels among the most populous counties in California from 2000 to 2018, where this dotted line represents the current recommended level of 0.7 parts per million. And the plot on the right shows the variability by water system in Los Angeles County, which has the largest number of water systems. And you can see there is a substantial amount of variability both across and within systems over time. And in particular, you can see a large increase in the water fluoridation levels around 2007, which is when the Metropolitan Water District started fluoridating the water that it delivered to Southern California districts. And there was also a decrease in 2015, which is when the recommended level of fluoride changed from a standard that varied depending on the ambient temperature to 0.7 parts per million for all districts. So we determined that water fluoride levels are likely to be a function of urbanicity, the size of the water system, environmental co-exposures like ambient temperature, public finances, and the trust in government. So once we linked the birth and the fluoride levels, we included any births where the parent's address was able to be geocoded, where the fluoride levels were available, the outcome variables and the covariates were not missing. And since our goal was to estimate the effects of this hypothetical intervention of reducing water fluoride levels on birth outcomes, we used a linear regression model with a natural cubic spline to allow for nonlinearities in the effects of fluoride. And we adjusted for individual level characteristics, including maternal age, race, ethnicity, insurance type, educational attainment, and the month and year of conception. We also adjusted for the water system size, the temperature and urbanicity at the county level, and we included county level unemployment and income inequality as proxies for public finances and the trust in local government. And we also included the arsenic levels in water systems as a potential environmental co-exposure, as naturally occurring fluoride and arsenic often occur together. We then predicted the outcomes if fluoride levels that exceeded 0.7 parts per million were reduced to 0.7 and did the same for 0.5. And then we used a clustered bootstrap for inference. So first, these are results for birth weight. So the hypothetical intervention of reducing fluoride levels to 0.7 parts per million, we saw decreases in birth weight of about 2.5 grams on average. And for the intervention reducing fluoride levels to 0.5 parts per million, we saw reductions of about 5 grams on average. So we hypothesized that reducing fluoride would improve birth outcomes, which usually translates to an increase in birth weight. So this was in the opposite direction of our hypothesis. Next, we looked at the change in preterm birth, and we saw no associations with either of the hypothetical interventions. Similarly, for small for gestational age, we saw no differences in risk with either of the interventions. However, we did see some small reductions in the risk of large for gestational age of about 0.1% associated with both interventions. And the estimates for the intervention for the 0.7 parts per million were slightly more precise. So in conclusion, we found very small but negative associations of hypothetical interventions of reducing fluoride levels on birth weight and on large for gestational age, but we saw no effects for preterm birth or small for gestational age. So the next steps in this analysis are to continue filling in some of the missing fluoride levels from outstanding FOIA requests, and also to evaluate whether there are heterogeneous exposure associations by maternal and infant characteristics or environmental co-exposures. So for the R00 portion of this K99 R00, I'm going to use data from the 2 pregnancy cohorts that are a part of ECHO program, which is a 7-year initiative by the NIH and is the nation's largest study of pregnancy and child health, with linked longitudinal pregnancy and child cohorts of more than 50,000 children. So the 2 cohorts I currently work with are the Chemicals in Our Bodies cohort in San Francisco and the Illinois Kids Development Study in Urbana, Illinois. And in these 2 cohorts, I'll measure fluoride levels in maternal urine that was collected during the 2nd trimester and assess whether this urinary fluoride is associated with continuous measures of gestational age or fetal growth. And I'll also assess whether there are heterogeneous exposure associations by co-exposures in maternal and infant characteristics. I also can see several next steps for this fluoride work. So these preliminary results suggest that fluoride might be associated with an increased risk of LGA, which might indicate a link with gestational diabetes, as one of the greatest risk factors of gestational diabetes is having a baby that's large for gestational age. So looking at pregnancy complications is a next step. And I'd also like to conduct a population level study on water fluoridation and child neurodevelopmental disorders, because this hasn't been done yet. I also recently submitted an application for an R03 to study the associations of fetal loss with climate-sensitive drinking water contaminants in California. And in general, I'd like to continue studying both social and environmental drivers of miscarriage and stillbirth, including community violence and wildfires. Very quickly, I'd like to also highlight some of my ongoing work in science translation. So in 2020, I was selected as a Earth Environmental Health Scholar, in which I worked with journalists at The Conversation to learn about effective science communication and environmental health. And as part of that, I wrote an op-ed about my paper on fatal police violence exposure in preterm birth in California, which found increased hazard of preterm birth, especially among Black people when a Black person was killed nearby. I also participated in a collaboratory with UCSF's Preterm Birth Initiative to discuss the findings of this paper with community members, researchers, clinicians, and activists. I also wrote a blog post for the Program on Reproductive Health and the Environment about my study on water fluoridation and fluoride levels, and conducted a comparison of risk of bias assessments in a systematic review to illustrate how the tool you use in a systematic review can affect the conclusions about the quality of a body of evidence, and thus can influence policy recommendations. So my goal with this work is both to make research findings more accessible and actionable to the general public, as well as to improve the science to policy pipeline. So as someone who works at the intersection of social and environmental exposures, I'm really excited to use rigorous methods to collaborate with colleagues across disciplines to ask novel questions about the drivers of health inequities. So the ultimate goal in my research is to understand how these exposures shaped by history can perpetuate or continue to perpetuate health inequities. And as we document these relationships, we can hopefully mobilize towards removing toxic exposures to promote better health for new generations. So as Maya Angelou said in her poem On the Pulse of Morning, history, despite its wrenching pain, cannot be unlived, but its faith with courage need not be lived again. So I'd like to acknowledge the collaborators on the projects I presented today and the funding that supported me. So thanks so much.
About 10 minutes.
Yeah.
All right. First of all, thank you so much for having us. A lot of work kind of taken still, so it's all very impressive. I really just wanted to kind of hear some of your thoughts, I guess, underlying in the second study. You could talk about some of this, like the rationale behind the choice of mediators and kind of what led you to kind of look at some of those and just kind of hearing your thinking.
Yeah, so my dissertation was really around community violence and pregnancy outcomes. And I wanted to do a mediation study because understanding how community, I think at that time, there was a lot of criticism around kind of this black box epidemiology. Like we look at one thing, we look at the other, we had no idea how they're affected. So I was kind of trying to get a sense of how these things might be connected. And as I mentioned, to identify potential places for intervention as well. And so we kind of just tried to find things that were likely based on the literature to be associated with exposure to community violence. So stress related. Anything stress related that we could then have a diagnosis code for in the hospitalization record, as well as anything that was likely to be connected to preterm birth. So for instance, preeclampsia is something that is hypertensive disorder of pregnancy is likely, there's been suggestion that it can be stress related, and it is also associated with preterm birth. We decided to limit to early preeclampsia to get around the issue of sometimes preeclampsia can be diagnosed postpartum, is more likely to be diagnosed postpartum among people who deliver preterm, so that's why we focused on early preeclampsia. Asthma was also something that has been shown to be linked to community violence exposure, mostly among adolescents. There hasn't been a lot of work in pregnant women, but because it has connections with the immune system, there's a lot of immunoregulation that happens during pregnancy, and preterm birth is thought to be affected by those. So we thought that might be a potential mediator. Gestational diabetes was mostly a pregnancy complication that not a lot is known about it. And so we thought it would be good to kind of add to the literature. There wasn't a ton out there about that. Substance use was something that has been linked to community violence exposure as well as preterm birth. So that's kind of why we added that one as well. Covered all of the mediators. So yeah, basically it was based on the literature, and also, yeah, things that we thought were plausible, and then were also available based on the data that we had available.
So maybe just like one for substance use, is that focusing on the specific substances or just kind of broad?
So the substance use that we defined was any substance, and that was because was validation studies that showed, or also I feel like infection was also in there that I forgot to mention, but both infection and substance use had some validation studies using the hospitalization data that suggested the validity of them was good if you were looking overall, but not within specific subtypes. And so that was kind of a data quality thing, but there has been strong associations between certain types of substance use and preterm birth, in particular cocaine use during pregnancy. Not as much information about other forms of drug use. Obviously, it's very difficult to study that during pregnancy. So yeah, those were the kind of motivations for those. Thank you. Yeah.
So I have a question about measurement. I really enjoyed the talk, but I was taken by the connection of the Google and the additional data that you got. So it's a two-part question. One, does everyone in the Bay Area just know someone in Google? And they just arrange this? And the answer to that is no, but I'd like to hear if you did make the connection to Google, the air quality. And then my other question is, it seems like it gave you so much better data than I guess whatever the standard, are those the EPA air quality monitors that are placed like in the middle of Oakland or something all the time. But I guess having done some of these, one of the great lengths to get hyper local environmental and geographic data like that, my experience is that oftentimes it doesn't provide that much more utility, but comes at great cost. That doesn't mean we shouldn't always pursue it, but I just want to know, like, what's the second question is, what's the marginal value of getting hyper local data? And do you think you would have gotten the same result if you didn't have
it? In this case, I think we probably would not have. I mean, basically everyone in the study population would have had the same air pollution monitor levels because they all lived sort of in the catchment area for that air pollution monitor. I mean, maybe if we did some smoothing between nearby monitors, they would have been slightly different, but we really wouldn't have been able to capture that variability. And I think maybe in this case there were it was especially useful kind of because of what I mentioned about the different topographies and the different sources of pollution, and how basically where the highways are and where the hills are, and basically just the air patterns in Oakland, why you can see such wide differences kind of block by block. I can see that. I mean, I think the fact that the associations were stronger for the kind of slightly larger exposure characterizations means that, like, because obviously people aren't at their homes all day, every day, you know, at least in this time they weren't, which was in 2016. You know, maybe we're not capturing all of the, you know, people are commuting to work or, you know, have different exposure levels. So maybe slightly broader is actually better. But in that case, I think there was a big utility to doing this hyperlocal approach. And there were some validation studies too that have shown basically that even these mobile monitoring, if you match it with an air pollution monitor that's like at someone's house, it does a very good job of actually, like, you know, on average, they're very similar. In terms of, does everyone in the Bay Area know someone at Google? Definitely not. And actually, Joan Casey was the PI on that project. And I think Josh Apte has some connections to Google that are kind of unique. And so I don't know anyone else who has data from Google, although I wish they were a little bit more open to collaborating with public health people. Yeah, I will say one of the drawbacks of that approach is that you get very good spatial resolution, but not good temporal resolution. So because, you know, you need to have some stability in the estimates. Basically, they're averaged over all those times that the cars drove by each block during the years that they were driving. And so you can get good long-term average exposure associations, but, you know, you can't do like a day by day or a, you know, the reviewers of this paper really wanted us to do like critical windows of exposure, which is just not something you can really do with this type of data.
We have a question online. Laura, would you be able to answer the question, please?
Sure. So Pam Factor-Litbeck says, thank you for the great talk. Many studies which evaluate contaminants or air pollution focus on identifying critical weeks in which the pregnant person was exposed. I didn't see this in your analysis. Do you think that such identification of critical periods is not relevant for ultimate policy?
So I think one, I kind of explained why we didn't do the critical window assessment in the first study. We just didn't really have the data available. In the other studies, it was kind of not possible based on the exposure data that we had. I do think it is important to understand the etiology of how these exposures are affecting pregnancy outcomes, I think it is important to know when exposure during pregnancy affects outcomes, because that helps us learn about kind of the biological processes that lead to adverse outcomes, which is still something that's really not well known in pregnancy. Whether or not it's relevant for policy, I think less so. Mostly, I think it's relevant for like clinical decision making potentially, but you know, overall, I think policy making, if you're going to say reduce an exposure or increase a benefit, you know, it's not going to be during the specific, you know, window of your pregnancy when that's going to happen. It's going to kind of just be a more, I think, general and yeah, it's going to be kind of your exposed, your unexposed type situation. So I think it is slightly less relevant for policymaking, but very important for clinical decision making and personal decision making, and yeah, understanding the etiology of these outcomes. Yes.
Really great work. I had a question about the first paper. You mentioned that in the levels, the area neighborhood were lower than across the state, but it showed, I think, higher risk reductions when compared percentiles. So I was wondering if you had any thoughts on whether that could commit to.
Oh, yes. So and correct me if I get it wrong, but yeah, so the question was, we observed NO2 pollutant levels that were kind of far below the regulatory standard, and yet we still saw the strongest associations and the biggest potential reductions in preeclampsia risk associated with reducing NO2. So what does that mean in terms of NO2 exposure levels? And I guess what I would say is, yeah, basically to me just suggests that harm can still be done at much lower exposure levels, and that the EPA should really, one, consider lowering their standard and or like, so there are some protections for pregnant women under the Clean Air Act, some special considerations, and that maybe those can kind of be a reason why the standards are lowered even further. I will say that I think part of the reason that exposure levels are as low as they are is there has been a lot of environmental justice activism in Oakland to try to reduce these pollutants, because there like a lot of trucks go through neighborhoods to go to the Port of Oakland. And so there's been a lot of local action around trying to make sure trucks aren't like driving by residential streets all the time, and to kind of make the transition to cleaner vehicles as well.
Really interesting. This how much, you know, California, I feel like has done is maybe leading the nation in having the standards during pregnancy and after pregnancy, specifically for pregnancy. And so I was thinking like, is California doing a better job? And you know, also thinking about things and people with, you know, people with certain resources. Of that on the that would make sense and actually thinking about how, if you have any ideas or thought about ways to add into your research, similar to how you talked about differential fetal loss.
Do you think, yes. Oh, yes, I can repeat it. Okay, the question was about measurement of preeclampsia and how California might have higher rates because there's more attention paid to it and kind of better surveillance around preeclampsia, especially because there's, you didn't say this, but there's this big maternal mortality push in California to try to fix that issue. And preeclampsia, especially postpartum preeclampsia, is one of the leading causes of maternal death. Basically, you have blood pressure spikes insanely after delivery. And if you don't know to recognize those signs, it can be fatal. And you have to get rehospitalized and take magnesium, and it's really bad for both the mother and the baby. I think that's an important issue. And also, I think especially, you know, there's a lot of monitoring that happens at the end of pregnancy, but if you're delivering preterm, then there's less monitoring, you know, day to day that's happening. If you're delivering like, you know, post-term, there's a lot more monitoring that's happening around blood pressure in particular. But if you're delivering preterm, you might not even, you know, maybe you would have gone on to have preeclampsia, maybe, yeah, people who have more resources and or just are more attuned to this issue, for instance, have a blood pressure cuff at home that they're using to make sure that everything's okay. And if it's not, they're taking themselves to the hospital. That's something that has happened. I know of a few cases of that, but yeah, I think it's an important issue, and one that I think is understudied. And yeah, I think one of the challenges is that because it is like still somewhat rare, and so it's more difficult to study kind of in the pregnancy cohort type approach. For instance, the pregnancy cohorts I work with like exclude people if they have preeclampsia, which is really annoying. But I think because it, you know, they're looking for like a specific healthy pregnancy. And I think that limits our ability to understand that issue. I also think that it's harder to do that with this kind of administrative data approach to really know what you're missing. But I think there's a real opportunity there to devise better way to follow people and better diagnosis, maybe some sort of intervention study where you know, give people blood pressure cuffs and have them record their blood pressure every day or something. I don't know, but I do think more work needs to be done around preeclampsia in particular.
Yes, thank you very much, everyone, for coming. Great talk. And the research that you can follow. Thanks so much, Dana, and thanks everyone.